Hi, my name is Noelle Mitchell, and I'm going to be talking about my DMP scholarly project, the National Early Warning Score System. To start, I'm going to talk about my committee. So this included 2 faculty chairs from Maryville University, Dr. Amanda Hoffpower and Dr. Maria Snell, and it included community members from the facility. Brandy Kaysen, the unit's clinical nurse specialist, Amy Behrens, the unit manager, and Brenda Williams, another clinical nurse specialist. So the background and significance of the early warning systems are that they've been proven to improve patient outcomes. So the early warning systems are the overall arching category, and then they can be further defined into the modified early warning system or national early warning score system. So it started with the early warning system and then was later modified. The Muse system can be tweaked for unit-specific needs, like if you're a urology floor, you can add urine output. However, it was further tweaked to be the National Early Warning Score system, which is standardized and cannot be changed. So many facilities use both of those. The National Early Warning Score system that we're going to be talking about has 7 components. It's respiratory rate, systolic blood pressure, oxygen, SpO2, temperature, heart rate, and level of consciousness. Depending on what those scores are, it will calculate an overall score to determine whether or not the patient is high risk or needs an intervention done. So at a level 3 trauma center at a rural military facility, it was found that there were nursing barriers that stopped nurses from being able to use the system appropriately. The specific aims of this project were to determine barriers to the implementation of NEWS on that multi-service ward within the military treatment facility. Another aim was to educate nursing staff on the protocol and policies of the NEWS system, to determine if NEWS compliance improves after an educational intervention when compared to no educational intervention, and overall to enhance nursing compliance of the NEWS system. So when reviewing literature, NEWS is newer than the early warning system and modified early warning system. And due to COVID and that huge break of research that was not completed, a lot of the literature was found to either talk about the early warning system or the modified early warning system. So for the purposes of this project, the review of literature includes not only the early warning system, which is the overarching category, but also the modified early warning system, which is very similar. So numerous studies found that early warning systems and Muse were able to detect clinically deteriorating patients, recognize this early on, increase monitoring and vital sign documentation, and overall decrease unplanned ICU admissions, code blues, and overall mortality rates in the facilities. There was also a correlation between the early warning systems and a decrease in cardiac arrests, an increase in the frequency and accuracy of vital sign documentation. Additionally, there was some nursing attitudes that were researched regarding the early warning systems and the modified early warning system. They found that Muse was linked to an increase in nursing self-efficacy and confidence in decision-making. However, they also found that there were negative attitudes associated with Muse and that it felt very demeaning to utilize the system as it overrid nursing judgment. However, nurses also felt there was more collaboration amongst the multidisciplinary team when using this system because it required, based on the level of the score, a certain amount of intervention with the patient in terms of providers, charge nurse, things like that. So for this project, I used Kurt Lewin's change theory as my theoretical framework to guide the project. His theory is a 3-step change model that has to do with unfreezing, change, and refreezing. The first step of the project, unfreezing, makes you have to decrease the force or whatever is impacting the behavior that the current staff is utilizing. So for my project, this phase was done by collaborating with the nursing staff and unit managers to figure out what the nursing perceptions of news within the ward was. The next step is the change phase, and this is when you begin to change thoughts, feelings, behaviors towards the new practice. So we did this by administering a educational program and teaching the nursing staff about news and assisting the staff members to begin incorporating the change into their practice. And then the last step of Lewin's theory is that of refreezing. In this stage, this is where you make the change permanent and habitual. For the purpose of this project, this step was done after education regarding policies, procedures, after all questions were answered, when we had the staff appropriately implement the system into their practice. For the methods and design of this project, we collected, so the first group of data was collected via a news questionnaire that was disseminated to all staff members to fill out. It was a 10 question questionnaire, and it really focused on their level of knowledge and their attitudes towards the news system and any concerns they had. And then the other method that was used in this project was a pre and post interventional data collection. So there was a pre-data collection after administration of the questionnaire, but before the educational intervention, to collect data to see how they were properly using news at the time. And then there was an educational intervention that was provided in the form of a oral presentation, posters around the unit, and badge reels that were given to staff members. And then to conclude, there was a post-intervention data collection period where there was a retrospective chart review, and all of the charts were audited to see if staff members were appropriately using the system. Like I mentioned in the previous slide, the data was collected using a retrospective chart review with pre and post interventional design, so collection of data before the educational intervention and collection of data after the educational intervention. So there was a 1 week pre-intervention data collection period, as well as a 1 week post-intervention period data collection. The questionnaire was administered over 2 weeks, and then the educational portion intervention was conducted over 2 shifts to ensure that both day shift and night shift were all receiving the same education. The data that was collected from the chart reviews includes the following: the date of collection, the patient initials, the patient's age, number of vital signs taken within the 24-hour period, and number of news completed with the associated vital signs during the 24-hour time period. So it recorded how many, with each set of vital signs, were there a news associated with the vital signs, yes or no. Additionally, it was important to record the patient's age because this unit also saw pediatric patients, but for the purposes of this project, we were focusing on adult patients over the age of 18. So our sample size our sample characteristics are as follows. For the questionnaire, participants who were allowed to utilize the questionnaire included nursing staff who worked on the unit. However, this did exclude those who were not directly working in patient care. So if there was nursing secretaries, the unit manager, the clinical nurse specialist, or anyone else on the unit who did not play an active role in patient care, direct patient care that is, they were not to utilize the questionnaire or participate in the data collection. And then for the chart review, the participants were between the ages of 18 and 90 years old. They were admitted to the multi-service ward, which is the unit in discussion. They could be any gender, racial, or ethnic background, and they could have any admission diagnosis as well. For data analysis, the statistical testing that I selected was an upper tail Z test, which is a directional form of the chi-square test. I selected this test, one, in part of the design where it found the difference of 2 proportions, which is what we were trying to find in this project, pre-education versus post-education intervention. So that was the main reason. Additionally, I consulted with the Maryville University statistician, Dr. Pals, to kind of go over what would be most beneficial for this project, and he was in agreement that this was the most appropriate statistical testing because it could find the difference of the two proportions. So for results, there is a bar graph that shows the difference between pre and post intervention news that were collected. So you could definitely see graphically what the results were. However, overall, we were able to collect 16 news questionnaires from nursing staff. The common theme with the questionnaires was lack of familiarity of the protocol and issues with the electronic medical record system, which I will talk about later on. But those are the biggest themes that we noticed throughout the questionnaires. And then for our pre-intervention sample size, there were 733 vital signs conducted, with only 16 news calculated. So it should be for every set of vital signs that there is a news associated with it. But for pre-intervention, out of 733 vital signs, only 16 news were calculated. And for post-intervention sample size, we had 328 vital signs conducted with 15 news calculated. So the biggest limitations in this study, hands down, was the electronic medical record. So recently as in the facility before the implementation of this project had transferred over to a new electronic medical record system. So that record system had only been there for a few months. We're talking about 6 months to be exact, before this project took place, which was definitely a source of contention with the staff members, especially since that program, the electronic medical record, had difficulties with the news system. So some of the issues that they experienced with the electronic medical record system was that the news score only populated after vital signs were entered, and the person who entered those vital signs refreshed that page. So, for example, a nurse would put the vital signs into the chart and save them. Other people could go into the chart and see the vital signs. But until that specific nurse who entered the vital signs refreshed the page, the system would not calculate a new score. The vitals were saved at the correct time, but a score would populate at a random time. So if that nurse took a set of vital signs at 0800, saved them, walked away and took care of other patients, and refreshed that screen at 0930, there would be no new score under the 0800 vital signs, but there would be a random 0930 news score with no vital signs attached to it. So it was very difficult to determine which vital signs were associated with which news because they were not charted in the correct time frame, which was not the fault of the nursing staff, but more errors with the electronic medical record. Another limitation of the study, or an issue that we encountered, was the charting system didn't differentiate where the vital signs were obtained. So for example, the emergency room, the vital signs, if the patient was a direct admission from the emergency room, which a lot of admissions are, you could not tell which vital signs were taken in the emergency room and which vital signs were taken on the unit. So the emergency room is not required to do news scores, unlike the medical ward is. So that presented a problem because it was difficult. You were unable to tell where these vital signs were being taken and on what unit they were being recorded, essentially. And then the last limitation for the study was that transcribing of data was by hand from the electronic medical record to a data collection sheet, which was used for this study. So I personally transcribed all of the data. I'm also human, so that's definitely a limitation. There was no way for the system to pull a report for vital signs, which would have made the project a lot easier and also reduce the risk of transcription error. So to further discuss the results that I talked about a few slides back, when you compare the pre and post intervention data, there is an overall 2.39% increase in news compliance amongst the nursing staff after the educational intervention. This was our hypothesis as well as the predicted outcome of the study, so that is great. The statistical significance of the study was that the p-value was less than 0.05, meaning that the p-value, because it's less than 0.05, that the results are in fact statistically significant. So we were able to reject the null hypothesis as there is evidence of change from the normal. The confidence interval of this study had a lower limit of 0.10% and an upper interval limit of 4.8%, indicating that there was a small chance that if we redid the study, we would get the same exact numbers. For the power of the study, it was 0.66 or 66%. The maximum power of a study can be 1.0, so this indicates a medium to high strength of power for this study. Implications for practice. So overall, this project showed that formal education to nursing staff members can help increase their compliance of unit protocols. So this goes for any type of processes or tools or protocols that units have. And then specifically, this project was able to say that for early warning system programs such as the news, formal education helps to increase nursing staff compliance. Further implications for healthcare policy include an educational intervention for routine basis to ensure increased nursing compliance. For example, if you have a high staff turnover on the unit or new staff members who are being hired, ensuring that there's proper education being routinely provided regarding this system so that when new nurses come or new staff members are hired, they are able to understand how the news works, the importance of the news, and how to properly chart it. So in conclusion, implementation of an educational intervention to nursing staff on an inpatient multi-service unit increased nursing compliance of the system by 2.39%. Overall, the study was found to be statistically significant with a p-value of 0.0136 and was also considered to be of strong power at 66%. It is recommended that other units within the hospital or other hospitals that are using this system should apply an educational intervention for their staff members who are responsible for charting the system in order to increase nursing compliance. Additionally, further research is recommended on the effect of educational interventions on other types of nursing protocols with poor compliance. So, in other words, it's recommended that studies of different protocols that are experiencing the same struggles where their staff members are not complying, research should be done to see if educational interventions would affect those protocols. And lastly, like I mentioned in the previous slide, it's recommended that a routine educational intervention be provided for nursing staff for news, especially on the multi-service ward, to ensure continued compliance. And that's also part of Kurt Lewin's change theory to ensure that the change remains permanent. It is recommended that frequent and continued education be provided, such as refresher courses or refresher teachings. And now for any questions regarding the project. And lastly, here is a list of the references used in this presentation. However, there are additional references available upon request that were used throughout the entire project as well as the project paper.